And that doesn't distinguish between natural immunity or vaccine-acquired immunity. It's the percent or the prevalence of the population that is immune. I even put forward a bill because of this difficulty with recognition of natural immunity. It was as if public health professionals and medical doctors lost their sense of their education in denying that there was such a thing. I put forth a bill to mandate testing by all insurance companies of both humoral immunity and T-cell immunity so people could document that they were immune and then not be fired from a job in the military or in the healthcare workforce or another job. And so if I sound passionate about this, I am extremely passionate about it because we have to get the science right. We have to get the messaging right. And the message was very wrong when we did not acknowledge infection-acquired immunity. We can do both. We can walk and chew gum. We can say there is infection-acquired immunity, but depending upon your risk level, it could be very detrimental for you to wait to get infection-acquired immunity. We can do both of those things, and it's important to do them. So I apologize. You can see the lack of responsiveness I got from four public health officials. We knew early on in 2021 about infection-acquired immunity, about a better level of immunity from both infection-acquired and COVID vaccine. And Dr. Makary, you conducted one of the first long-term studies to look at COVID antibody levels nearly 2 years after infection. You know, what was it like trying to do this study, and did the NIH or CDC support your inquiry?
It was nearly impossible to study natural immunity. My Johns Hopkins colleagues and I published a study on natural immunity, basically drawing the blood of people who had COVID in the past and did not have vaccines to measure their antibody levels. And we found those antibodies were present and durable up to nearly 2 years after infection. Why did the NIH or CDC not invite some people who were infected in the early days in New York to test their blood? No one was supposed to talk about natural immunity. It was misinformation, even if it was scientifically valid, because they thought maybe somebody might try to get the infection. So let's not be honest with the American public. That's the basis for it, and that's what public health officials told me privately.
So like me, you have no idea why they ignored it.
There was no money for it. They didn't want to talk about it, and they wanted to promote an indiscriminate, all-or-nothing vaccine strategy that meant all the vaccines could be 4 today or 7, depending on your age, or nothing. And if you don't do all of them, you're not fully vaccinated, and you don't meet the criteria of the Novak-Djokovic doctrine. You're not allowed to travel into the United States. You're not allowed to play tennis outdoors. It was an absolutism. That's what ruined public health credibility, is not being honest.
And I apologize. Did this also lack of acknowledgement of infection-acquired immunity play into how often we recommended people to be boosted and the age at which they should both get COVID-19 vaccine and boosters, even if they had both infection and vaccine?
Yeah, for public health officials, it was all or nothing. Doctors on the ground were customizing their vaccine recommendations. You've had COVID twice, including 4 months ago. I'm not going to recommend the booster because you're young and healthy and there's no data to support it. That's how doctors practiced medicine, but that was labeled misinformation by the medical elites.
Thank you so much. And if I may, I'd like entered into a record a letter that the Doctors Caucus sent to Dr. Walensky in September of 2020, asking questions and making inquiries into infection-acquired immunity and looking at real-world evidence and data and research from other countries.
Without objection.
Thank you, sir. I yield back my time.
I now recognize Mr. Mfume from Maryland for 5 minutes.
Thank you very much, Mr. Chairman. I want to take exception with something that I heard here in this hearing, and that is that minorities, racial minorities across our country had a greater sense of immunity and were impacted less by this disease. In fact, infection-acquired immunity and all the other things were even more dangerous in minority communities, both when looking at death rates and broader inequalities in the healthcare system. In fact, the total cumulative data that we have and is available to all of us show that Black Americans, Hispanic, American Indians, Native Alaskans, Native Hawaiians, and Pacific Islanders all suffered higher rates of COVID-19 cases and deaths. That is the record. So the suggestion from some that, well, it was not that bad in these minority communities, I think is a biased, xenophobic, and absolutely incorrect proposition to be putting forward. So let the record really reflect that those communities got hit harder, and those death rates were higher, and those cases went up. I think what we ought to do here is to sort of transport ourselves back to the dark, difficult days of COVID. We're looking back now as if we're looking through Alice in Wonderland's looking glass at what took place, and we all run the risk of being Monday morning quarterbacks. What we were dealing with in real time. Were there assumptions that were incorrect? Yes. Were there efforts underway to try to grab and get a hold of this? Yes. Did some of them work? No. Did some of them work? Yes. But when you're in the middle of a crisis, you're not trying to look to find the perfect way out. You want a way out to be able, particularly in this case, to save lives. So it's great to look back and say, if we could have, should have, would have. But the fact of the matter is that this entire nation was dealing with something in real time. People were washing their hands and told they need to wash them 20 to 30 times a day. Many of us thought that this disease was transmitted by touching. Others thought it was transmitted because of closeness. There were quarantine times that varied from 7 days to 17 days. Students on college campuses and other young people were afraid to get a vaccine because the social media posts were saying it will create infertility among you. We were washing our groceries as they were being dropped off at our door before we brought them into our homes. So we were in real time. And in real time, you're going to get some things right and you're going to get some things wrong. But at the end of the day, the real key is to try to find a way to save lives. Now, my bigger concern, Mr. Chairman, is that we don't play into this notion of vaccine hesitancy. It takes us down a dark, difficult path, and one that we all, I hope, don't want to go down, particularly when we see now that measles, mumps, and even polio are starting to reemerge in this country because of hesitancy, in many instances by parents to want to get vaccines for their children, and in other instances just because people have this boogeyman theory that somehow or another, if you put something in your arm that has been scientifically and medically researched and approved, that it's going to distort you, change your DNA, create a monster, or do something far worse. So I hope and really pray that this hearing does not add to this notion of vaccine hesitancy. Is it important to look back? Absolutely yes. That's the only way we can identify things that we agreed with, disagreed with, things that worked and didn't work. But to assign blame when we were all trying to figure this out together, I think is absolutely the wrong way to go. And that means Republican blame, Democratic blame, independent blame. We were all in real time. So it troubles me when I continue to see the sort of political machinations that are taking place, pointing the finger and blaming and say, we created a worse problem than we had. Actually, I thought we did pretty good getting out of the problem that we did have. And I think we have our larger medical community to thank for that, and the number of people who were on the line who were not physicians, but regular men and women who worked in jobs where they were very susceptible of becoming ill, who went to work every day, who we don't even talk about now because we took them for granted. So we've come a long way since we were in the middle of this crisis, and I think it's important to always keep that in consideration and in the right context. I yield back. Thank you, sir.
I now recognize Ms. Lesko from Arizona for 5 minutes of questions.
Thank you, Mr. Chair.
Actually, if I may, before you begin, we'll reset the clock. Mr. Mfume, you made a statement, and I could recognize from the panel that they're confused on who you thought made a statement, and I'd like them to have the opportunity to maybe clarify or rectify or respond to the accusation of what someone said. You know, which
Sir, you are the chair, so
which doctor did you? I'd like to let them have the opportunity.
Dr. Smelkinson.
Thank you.
Yeah, thank you for giving me the opportunity to respond. I actually do agree with you, and I said that the lower income communities did tend to have more natural immunity. They were more impacted by COVID-19. They were also tended to be less vaccinated. I think that those things are linked. When it came to the vaccine mandates that made no exemptions for natural immunity, my point was that those mandates were not very equitable because you wouldn't, if you're not making exemptions for natural immunity, those communities weren't able to live up to the mandate.
Thank you. Ms. Lesko, you're recognized.
Thank you, Mr. Chair. And this is a great discussion because the purpose of this committee, from my understanding, is to try to learn from what we did right and what we did wrong. So when the next pandemic comes along, we're not going to repeat it, hopefully. So my first question is for Dr. Makary. In October 2020, Rochelle Walensky, who would later become CDC director, co-authored a memorandum published in The Lancet that stated, quote, "There is no evidence for lasting protective immunity to SARS-CoV-2 following natural infection," unquote. Was there any data at the time that would have supported her statement or refuted her statement?
Well, first of all, the absence of evidence is not the evidence of absence, and she should have known that all other viruses yield natural immunity with ultra-rare exceptions, including the 2 other coronaviruses that cause severe illness in humans. Both were studied to have long-term immunity. So I think it was intellectually dishonest, but even worse, she dug into her position as the data were overwhelming. Even to this day, the Yokovich Doctrine, in place yesterday in America, prevented teachers at federally funded schools from working. We won't allow people with natural immunity to work unless they have the full vaccine primary series. Well, guess what? We're hurting children from ignoring natural immunity. It's not historical. It's not looking back and blaming. It's right now. 160 schools in Missouri have gone down to a 4-day school week because they don't have enough teachers. They've left. Hospitals are understaffed. Response times are longer for first responders, not because of a historical mistake. They're still ignoring natural immunity. Even at my university, you can't go to school without the primary vaccine. Even if you've had COVID 3 times and we're in the ICU with myocarditis, you still need to get the COVID vaccine. That is intellectually dishonest.
Thank you. That's very passionate, very appropriate, because our last hearing we had was about school closures and how that adversely affected students. Did you bring this up? And I haven't done the research. So did you bring up the natural immunity, and were you shut down? Were you censored?
I was not censored. I always cited data, but I can tell you that natural immunity was considered misinformation by our public health oligarchs as they spread their own misinformation on many other topics.
In a related question to all three of you, in the early stages of the pandemic, do you believe that federal public health officials were aware of the centuries-old knowledge of infection-acquired immunity?
Yes, they were definitely aware of that, but even if they thought SARS-CoV-2 was different, certainly by mid-2020, there was a lot of immunological data showing that recovered patients had a very robust B-cell and T-cell response, and they were seeing that it was lasting over many, many months. So they did, and it was very similar to the T-cells that were made by SARS-1 that were still reactive almost 20 years later. So yes, I think they knew early on that natural immunity was strong.
I think they knew that there was some natural immunity. I would imagine that the question they were asking is, how much do you need to be protective? And, at the time, because there was so much disease going around, they had to make very difficult decisions as to what was going to be beneficial for the majority of the individuals.
Did you want to add anything?
If I could just add, because in my role as editor-in-chief of MedPage Today, the second largest trade publication read by doctors in the first 2 years of the pandemic, I asked, has anyone seen a healthy person who's recovered from COVID show up in an ICU? The answer was always no. Maybe there's somebody out there, but by and large are protected against severe disease in the first 2 years. It was always right in front of our eyes. Saying we don't have a New England Journal of Medicine study where the editors are your friends and they called it misinformation, that was establishment groupthink. And the reality is we always knew those precious life-saving vaccines should not have been going to people first in line, already immune with natural immunity, as thousands die a day. So it wasn't a philosophical point. Thousands of Americans died from natural immunity, and over 1 million people left the workforce, and we are still suffering in schools and hospitals, in all sorts of settings because of that ignorance, and they still have not issued any kind of apology, rehiring, or back pay in the vast majority of those instances.
Thank you, and I yield back.
I now recognize Ms. Ross from North Carolina for 5 minutes of questions.
Thank you, Mr. Chairman. And I'd like to start out, I know we've pointed a lot of figures in a lot of places on both sides of the aisle, but I want to commend the Biden administration's work in delivering and deploying COVID-19 vaccines. And there's no doubt that the strong coordination between public health organizations, governmental agencies, and healthcare professionals helped save countless lives. And that happened in my home state of North Carolina, where our Department of Health and Human Services went to every corner of the state, worked with Latino medical professionals, worked with the Native American community, helped the African American community overcome vaccine hesitancy from, a history of racial discrimination. And we need to praise the people who made sure that people who needed vaccines got them as quickly as they possibly could. And these efforts are a testament to our nation's ability to respond to a public health crisis. The rapid development, which I would give the Trump administration credit for, the delivery and the administration of vaccines was not only critical for our domestic response, but played a major role in the international community and was instrumental in saving lives around the world. We sent vaccines around the world. And our vaccine strategy strengthened our relationship with many of our allies and reaffirmed our commitment to addressing the pandemic on a global scale. I'd also like to address the fundamental representation that some, not all, of my colleagues on the other side of the aisle have made, which is that somehow infection-acquired immunity replaces the need for vaccine. We need them both. We need them both. While COVID-19 infections do confer immunity, it does not reduce the role that vaccines play in safely promoting widespread immunity. For example, any argument that assumes that everyone will survive a COVID-19 infection fails to take into account various risk factors that people face, particularly the elderly, and we saw that in nursing homes, people with underlying conditions, and people who are immunocompromised. And many of those people live in households with young, healthy people who might bring COVID into the home. My brother has lupus and lives in a household with teenagers. Dr. Tan, what risks do infections pose to the communities that I mentioned?
Actually, you bring up a really good point. Infection in those communities, so immunocompromised, the elderly, the very young, under a year of age, and those with, underlying comorbidities, infection really significantly increases the risk of the development of complications, hospitalizations, and dying from COVID-19.
And did we see people dying?
Absolutely.
And does vaccination reduce the threat of infection posed to these particular communities?
Absolutely.
Also, I want to talk about long COVID. Long COVID has been shown to be more frequent and more severe among people who are not vaccinated. Dr. Tan, how do other effects of long COVID factor into the vaccine versus infection-acquired immunity conversation?
So that's a very good point in that we know that if someone is vaccinated, they are significantly less likely to develop symptoms of long COVID. And the same is true for multisystem inflammatory syndrome, which is one of the consequences that we see both in children and adults, but much more in children. And those that are unvaccinated are much more likely to go on to develop MIS-C as opposed to those that are vaccinated.
In the few seconds that I have left, Dr. Tan, in your written testimony, you note the body of evidence for infection-acquired immunity is more limited than for vaccine-induced immunity. Can you explain this a little bit more?
So, I think what we're learning is that with vaccine-acquired immunity, we know that it does provide protection and that the amount of protection has changed a bit with regards to the emergent variants of Omicron that have now become the main players for COVID now. And so with that, we are able to produce a vaccine that is going to be effective and provide better immunity against the Omicron variants. Likewise, we know from one of the studies that the immunity that you get from infection-induced immunity prior to the Omicron does not protect as well against preventing reinfection with an Omicron variant.
Thank you. And